Hello, I'm Brian Lau. First of all, I'd like to thank American Acupuncture Council for having me back. Today, we're going to be presenting on some shoulder mobility. We're going to look right away from at a shoulder mobility drill with weighted clubs. So that's why I'm standing here. We're going to go over some movement aspects with that. These would be something you can do yourself, which are really great mobilization exercises to keep your own shoulders healthy. But also you could prescribe these to patients. We'll look at some caveats for when you can do that, when you might not want to do that. It might be a little too much depending on the stage of shoulder injury. This would also have implications for neck injuries. We can go over some of that in context. So let's go over that right from the start, but let's look at some movement aspects first. So I have a little bit of a bone model here. So this would be my left scapula and left humerus. So I'm going to put it sort of in front of me. Obviously, this would be behind the rib cage, but just to give a little bit of context. So we're going to be looking at this shoulder mobility drill that's going to work on the glenohumeral joint, of course. So we have good movement in that, but we're also challenging the strength so that we can do movement with stability and the joints not moving around excessively. But with any shoulder movement, we want to look at this sort of dance between the shoulder joint and the shoulder girdle. So for instance, you can look up something called the scapulohumeral rhythm. So with that, that's specifically in reference to abduction. As the body goes into abduction, as the arm goes into abduction, you want to have this following of the scapula. So it goes into upward rotation. The scapula is not moving real well. It's very probable that the joint will hit the head of the humerus up against the acromion, and that can pinch and compress and impinge on the supraspinatus tendon, biceps tendon. A lot of tendon type impingement problems can come from that. So it's a nice dance. You can look it up online. You can find the exact ratio of movement of how they relate to each other. But it's not just abduction. When the body does internal rotation in the shoulder joint, the scapula likes to follow into protraction. So it gives a little bit of room, a little bit of movement so that the joint doesn't get compressed in the front of the joint. Same thing with external rotation. Sometimes it likes to combine itself with retraction of the scapula, maybe even a little bit of a downward pull on the scapula. So there's a nice dance of movement between the scapula on the rib cage, glenohumeral joint. I could add to that the sternoclavicular joint so that this whole complex is moving in this nice unified movement. It's not just the shoulder girdle though. When I'm doing any type of movement like overhead, my rib cage is going to open and expand and move. So there's a combined movement that happens in the rib cage all the way down to the diaphragm. So that a lot of these movements take this whole range of motion of the upper body, thoracic spine, rib cage, shoulder blade, sternoclavicular joint, glenohumeral joint, in a combined activity that's organized and controlled, or at least we want it to be organized and controlled. There's a lot of neurology that helps link that. The phrenic nerve going down to the diaphragm has a lot of relationships to the shoulder joint and the shoulder capsule, but also the rotator cuff muscles. If I go on the right side, there's a little branch of the phrenic nerve called the phrenico-abdominal nerve that goes right into the liver, into the capsule of the liver. So any liver mobility problems are also going to potentially show up as especially right shoulder problems. So that's a lot to think about. We're going to not necessarily try to dwell on all of those as we're doing the movement. We're going to look at one key aspect and allow all of those other things to happen. So I'm going to put this down for a second, grab another tool. So we're going to have a weighted club. If you don't have a club, that's fine. I'll show you what you can do without one. It's actually kind of nice to start without a club. This is a 5-pound club. 1 or 2 pounds is really nice to start with. Or we can just have our thumb out. My arm has a certain amount of weight in it, so this is fine. All the movements we can do to get used to these movements, we can do without a club, or you can have a wooden spoon or something if you want to have a little bit of something that gives you an idea of where you are in space. That's one nice thing of the club, but the actual weight is useful too. So if you were to do this on an ongoing basis, maybe start with a 2-pound weight, 3-pound weight, and you can go up from there. We'll look at some options. So we're going to be holding the club at the base. I'm going to have my arm out at 90 degrees in elbow flexion. I'm going to start at about level with the opposite shoulder. So I'm in a little bit of internal rotation. My chest can be relaxed. Again, if you don't have a club, you can just stick your thumb up and that'll kind of give you an idea of the direction that you have. So the first thing I want to do is just warm up the joint. We're going to build a movement here piece by piece. So I'm going to go into external rotation and pull the shoulder blade back. So I should get my arm lined up to the side, my elbows level with my hand, chest is open. Then back into internal rotation, I can let my chest fold just a little bit. So right from the get-go, the driving force is the shoulder blade. I want to pull my shoulder blade open, or I should say pull it back towards the spine to open the front. And then I want to let the shoulder blade come into protraction. My chest relaxes. Retraction, pull the shoulder blade towards the spine, open the chest. So right from the start, we're working on the heart sinew channel as I go into internal rotation, and the small intestine sinew channel as I go into external rotation and pull the shoulder blade to the spine. So nice exercise for the sinew channels. All right, so this is stage one. But we're going to add a swing to this. So instead of me just turning my arm out, I'm going to let the weight drop and find that position again. Let the weight drop, swing. So it's a swing and a catch. Down, turn the arm, open the chest, catch. Down, turn the arm, close the chest, catch. So swing. You can go slow, or you can start speeding it up if you feel comfortable with it. So we're building a movement. This is a movement called mills. Okay, next thing. Swing, catch. Now I'm going to go overhead. I want my shoulder blade to be the driving force. So I want my shoulder blade to go into upward rotation. Hand behind the neck. Down, catch. Up, down. Up, I want to keep a stable base. Down. Okay, now we'll change one more time. Up, turn, throw, catch. Swing, catch. Cast it overhead, turn, throw, catch. So that's the movement. It's like a throwing motion, like you're throwing a baseball. But again, driven by the shoulder blade. So pull the shoulder blade back to open the chest. Upwardly rotate to point your scapula up towards the sky. Protract and down. Very nice. We can go the other way now. So over the shoulder, same shoulder. Pull the shoulder blade open, down. Swing, catch. Cast, open, throw. Swing, catch. Cast, open, throw. So one more time, swing and catch. Cast, open, pull the shoulder blade back, throw. All right, real quick, we'll do it on the other side, then we'll look at some various options, when to do this, how to do it with patients, or for yourself if you're having shoulder issues. So let's go quickly through it again. Internal, external rotation. External, pull the shoulder blade open, chest opens. Line the elbow up with the hand. So I don't want my elbow facing back. I want it under, level with the hand. Chest in, open the chest. Okay, we can do that with a swing. Let the weight drop, up, drop, up, 90 degrees, drop, up. Again, we'll go overhead now. So up, hide the hand behind the neck, throw, catch. Up, throw, catch. Okay, one more change. Up. I want to turn my body in front of the other shoulder. Swing, catch, cast, throw. Swing, catch, cast, throw. Other direction, over, same shoulder. Pull the shoulder blade open, to pull the chest open, down. Over the shoulder, retract the scapula, pull the chest open, down. So great movement to strengthen the shoulder blade, the shoulder joint, to strengthen and move the shoulder blade, and to kind of coordinate that activity with the chest and rib cage. This would be not a good idea to start with a 5 pound if somebody was having shoulder pain. Maybe that's where it's really nice to start with just the weight of the arm. But maybe they have a painful arc. Oh, that's causing a lot of sharp pain just to do that. They're not stable. They don't have strength to support that shoulder joint. They don't have the strength for that shoulder blade to roll up and upward rotation so that they have a comfortable, nice movement. And oh, it hurts to do that. Well, it's probably not a good exercise for them. You need to build them up to that. You need to give them a simpler exercise, a floor exercise. We'll look at some acupuncture techniques. There's a lot that has to happen before they can comfortably do this. Once they can comfortably go up, maybe starting with no weight, 1 pound, 2 pounds would be a good idea. Keep it small. Once they get coordinated movement, then, and they're feeling comfortable with that, 5 pound. 5 pounds pretty good. They get a little more comfortable, then they can go up more weight. So adding weight will create a little bit more challenge. So this is 10 pounds. So if I'm doing the same movement with this 10 pound weight, then that requires more force, obviously, but it's not just the weight. So 10 pounds and 10 pounds. Well, now this 10 pounds weighs a lot more than the other 10 pounds because of where that weight is sitting, farther away from my hand, and the torque that creates when I'm going head. I don't want to swing it because my camera is pretty close here, but when I'm going head, and if I were to swing that through, that's going to require a lot more strength on my part to be able to balance and manipulate this weight that's farther from my hand. If I were to move down even to the handle, even just holding that and stabilizing it is a lot more difficult because, oh, any little movement here, I have to do a lot more stability to support that weight since it's so much farther away from my hand. So those are ways you can increase and build on this exercise, but you don't want to start with a shoulder, a patient with shoulder pain, painful arc with that mace. You know, you may not even be able to start with the weight of their own arm. You have to build them up to it. So just some ideas, some things you can work with, go through step by step, maybe starting with that just internal, external rotation. If that's not excessively painful, just to be able to balance that weight in external rotation is going to start to strengthen and stabilize that joint. So that would be a good starting place. Then you can build until they get the full sort of movement of throwing. All right, so that's what I wanted to start off with was the mobilization, so we can start thinking about feeling, coordinating that activity of the shoulder blades with the movement of the glenohumeral joint and how that relates to the chest and all of the whole body. So what if they have limited range of motion? Let's go over some potential techniques. We're going to focus mostly on the pectoralis major because the pectoralis major has to lengthen to be able to get my arm back. It has to lengthen to be able to get my arm back in both positions, different fibers, but pec major is going to be one of the key structures that's going to limit mobility. If this pec major is held in a shortened position, I can only go so far. So I want to be able to have full range of motion, full ability to elongate in that pec major in all different planes. So we'll focus on that. I'll tell you from the get-go, serratus anterior would be another big one. Another day. We'll just focus on pec major for today. So I'm going to switch to PowerPoint and let's go over a little bit of information, a little bit of the anatomy, and we can look at some techniques for acupuncture and manual therapy. So let's get the slides up. I'm going to come a little closer. All right. All right, so here's some netter images. If we look at the left image first, let's look at the bottom left. We have pec major. So pec major is a really intriguing muscle. It has the clavicular head that's going up and attaching to the medial third of the clavicle. It has the sternal head attaching to the sternum. Then as we go down a little bit, we see costal fibers attaching to the costal cartilage. And that bottommost slip that you see kind of attaching into the abdominal fascia is the abdominal head. So we have really 4 heads depending on how it's divided. Some books look at it as 3 heads, but clavicular, sternal, costal, and abdominal heads are the way I kind of look at it. So interesting thing about that is they kind of play out with the yin channels of the arm. The clavicular head is part of the lung sinew channel, sternal head, part of the heart sinew channel, costal and an abdominal head, part of the pericardium sinew channel. Those fibers have to organize themselves with the muscles of the back, such as the rhomboids. So if we're looking at the sternal fibers and we were going into that external rotation movement with the arm down, pec major has to elongate, rhomboids pulls the shoulder blade back towards the spine. So it's a balance between the heart sinew channel and the small intestine sinew channel. We start from internal rotation. Pec major is in a shortened position. As it goes into external rotation, infraspinatus, teres minor, part of the small intestine sinew channel are firing, while the pec major is lengthening. So they have this yin-yang relationship of one letting go, one shortening. So we don't have time to go through all the channel relationships for each of them, but that's one to start with. We'll look at a few of them, though, as we go into the PowerPoint. So lung sinew channel, clavicular head of the pec major is part of that. Pec minor is really the key muscle. That's also involved with this shoulder mobility exercise we were doing. So pec minor is going to have a tendency to pull that shoulder forward into an anterior tilt when it's shortened. If you remembered from that exercise we were doing, we had a pretty neutral position. The scapula is moving a lot, but we didn't have this jutted out forward shoulder at any point when we were doing it. If that's in a shortened position like that, we need to do a technique. Acupuncture is great to be able to release the pec minor. We can also use points along the channel, even muscles along the channel, like the flexor carpi radialis is a really great muscle to release the pec minor. So needling the motor point, if you've studied with sports medicine acupuncture, we teach the motor point for flexor carpi radialis. Fantastic distal point, even though it's not an official lung channel point, it's kind of part of the lung sinew channel. So really a fantastic point to release pec minor, but pec minor needling is something to learn too, with the caveat of being safe with it because it is close to the pleural cavity. That pec minor is going to have to be balanced by the large intestine sinew channel lower traps, which is kind of supporting it. Those have that yin-yang balance also. Upper fibers of serratus anterior, part of the lung sinew channel, those are those upper 2 slips. They have a different fiber direction than the rest of the serratus anterior, and they have different action. Again, we can come back to serratus anterior maybe another day. So here's the movement of the lung sinew channel. It's going to tend to pull that scapula like that top arrow, which is kind of pulling the scapula down into an anterior tilt, countered by the large intestine sinew channel, which stabilizes the scapula against that force of the pec minor. So if you go back and review large intestine sinew channel, you'll see that it goes down into the thoracic spine and follows those lower trap fibers. So nice combination to work with. Heart sinew channel was the one we kind of alluded to just before. The heart sinew channel includes pretty much the pec major. I think of the whole pec major, but really the sternal head in particular is the big one for heart sinew channel. This would be very important for that movement that we were doing, the mills that we were doing with the weighted clubs. We can also notice that the subscapularis is in there. Subscapularis is another big one, a really great muscle to learn how to needle, but it's not something for a webinar. That one's much better for classroom setting because you're going deep into heart 1 with really a 3-inch needle. You have to be very mindful of where the rib cage is so you can advance the needle towards subscapularis, but not towards the rib cage. So plenty of space if you do it properly, but too much room for error on a webinar. So classroom setting, another day. We will look at some needling for pec major though. So this relationship for the scapula is, again, we have protraction as the scapula pulls around the rib cage, moves away from the spine. Pec major is one of the big muscles that's going to contribute to that. And then that's countered by the rhomboids, which are multiple channels, but in this case, they're acting along with other muscles as part of the small intestine sinew channel. But all of that's happening with internal rotation, pec major, external rotation, infraspinatus, teres minor, also subscapularis, part of the small intestine sinew channel. So those have to coordinate their activity as one shortens, the other one has to let go. Then it changes phases and the other one shortens. They have to alternately elongate, contract, elongate, contract. So very much of a yin-yang relationship with those two. Pec major is usually the one that's overactive, and we'll be looking at a technique for that. Finally, the pericardium sinew channel. Pericardium sinew channel has a really interesting trajectory. It involves the serratus anterior, also these lower fibers of the pec major. All of those come down and blend in with this abdominal fascia, so it creates like almost like a fascial belt around the rib cage that can get too tight. So we need to loosen up that belt. Nice thing about that exercise we were doing is we had that in and out aspect with the chest. So we're starting to exercise and soften that sort of what can be a too tight of a belt around the rib cage for a lot of people. So the interesting thing about this one, though, is it wraps around the rib cage, which is discussed classically, but I take it a little beyond what you might think and into this rhomboserratus sling. So the serratus anterior attaches to the medial border of the scapula, and it links seamlessly with the serratus anterior. So much so that in recent dissection, and I've done this a few times, you can tease the fibers of the rhomboids and serratus anterior off the scapula and kind of layer, soft, slow approach, and then bring the scapula away, and you just have this seamless sling of tissue that you don't see really a break. All you see is where the scapula attached to it, but you have the serratus anterior rhomboids as one continuous structure. You can pull the scapula off. It's not something that if you were to take the scap off, you'd have to sew those back together. They're already united. They're already part of a sling. That actually then combines over to the contralateral side and blends in with the splenius cervicis and capitis. So this shoulder movement that we're doing can have good implications for neck pain for a lot of reasons, but one of which is that those splenius cervicis and capitis muscles become problematic for a lot of neck pain patterns. So we can needle splenius cervicis, we can needle splenius capitis if they're pain producers, but to be able to integrate them with the scapular movement so that there's this nice sling expansion contraction on either side is a really great way to keep those changes. So this exercise we're looking at, fantastic for shoulder problems, but neck problems, especially with splenius and cervicis pain patterns. Right, so the movement pattern with those and things you can look at, somewhat protraction and retraction, but also that upward and downward rotation of the scapula. Serratus anterior in particular upwardly rotates the scapula. So if you go back to this movement we were doing, there's a lot of times where the scap is kind of doing this circular movement of rotating up, around protraction, rotating back down, rotating up, retraction, rotating down. So that rotational aspect of the scapula is a very key movement of the pericardium sinew channel, moderated by the lower fibers of the pec major, serratus anterior, and then the rhomboids, and also the upper part of the traps. So I put this pericardium sinew channel in here, but again, this is an ebb and flow between pericardium sinew channel, Sanjiao channel. So lots of scapular movement, lots of things to think about. With just a small exercise, you're really working all three of those sinew channels. But I think the big one is pericardium and Sanjiao channel. That's the one that's the most prominent with the exercise we looked at. You have to twist my arm to say that because the other ones are. All right, so pec major is what we're focusing on for treatment. So you're teaching this exercise to somebody or you're doing it yourself. And it's hard to really get that arm back. It's hard to pull that shoulder back and have this nice open chest because of that pec major holding everything. So it's like this too tight of a grip on the shoulder blade and I can't get that movement. Or when I'm back here, I can't get my arm back because that pec major is pulling. So any of those positions that are difficult to get open in the chest, pec major is going to be a key player in that. And it's one that we can look at on the webinar. There's some concerns. We have to be careful. We have to know where the rib cage is. There's some cautions. I put this in the video, and this is a video that's up on my YouTube channel. You can reference later, or you can reference it directly from this webinar, which will be recorded. But it's safe enough. I think we can look at it in a webinar setting. I go through step by step. This is a way to needle the pec major. For those who have taken sports medicine acupuncture classes, Matt teaches it a little bit differently, which I think is great and maybe good for a class setting. I felt a little more comfortable with this one for a webinar setting because we're holding the tissue up away from the rib cage. So it's one that I use. I like it just for the reason that I like the technique, but it's also, I think, a really useful one to have on the YouTube channel and have on a webinar because it mitigates the risks by lifting the tissue away. So let's look at it. We're going to look at palpation for taut bands within the pectoralis major muscle, and we'll look at a way of needling this muscle safely. First, let's identify the fiber direction for the various portions of this muscle. The clavicular head runs from the medial half of the clavicle to the humerus, specifically the lateral lip of the bicipital groove. The sternal head runs from the sternum to the humerus. And the costal and abdominal heads run from the costal cartilage and the abdominal fascia, and then travel up to the humerus. With the arm down, the clavicular fibers run superficial to the sternal fibers, which run superficial to the costal and abdominal fibers. The layered arrangement changes when the arm is overhead. The different layers unwrap and then wrap again as the arm is brought down. Palpating for taut bands in the muscle can be helpful to gauge tension. Here I am palpating the clavicular head and assessing for tension. I can also push from inferior to superior or superior to inferior to feel which offers the most resistance. And I can advance the needle across the fibers in that direction. I have to take care that I place the needle in the same angle as the palpation and not change the angle deeper towards the rib cage. Now I am palpating the sternal head, starting from the sternum and noting a local twitch with palpation. This layer has a notable palpable band. An easy way to needle the pectoralis major is to grasp and lift the tissue away from the underlying rib cage. While grasping, you should feel the plane the rib cage makes. You then find the taut band and place your 2 fingers around it. Place the guide tube at an angle that allows the needle to penetrate the band, and then advance the needle into the pec major, directed towards your thumb and with the needle parallel to the rib cage. You can redirect the needle, but keep the needle parallel to the rib cage until you get the needle response. The needle is always directed parallel to the rib cage, and you should never aim the needle towards the rib cage. The needle is parallel to the rib cage, directed slowly towards the thumb, and not downward towards the pleural cavity. You should not perform this technique if you do not have an adequate sense of where the rib cage is, the plane it makes, or where the needle tip is in relationship to your thumb. The advancing needle can be felt by the thumb, but you need to be sensitive to this. You should not perform this technique on women with breast implants. Otherwise, working with women is essentially the same. Palpation will be the same, but you will not be palpating through breast tissue. You still have access to the muscle around the breast tissue. Let's go over this technique again on a female model. So when I'm palpating, I want to feel for the clavicular fibers. I can press into fibers going up from the inferior to superior direction, or I can palpate into them going from a superior to inferior direction, feeling for resistance. Doesn't feel particularly taut, so I'm not going to needle those fibers. I can palpate close to the sternum, looking for taut bands. There's a bit of one right there through that sternal fiber. Sometimes you'll even see a local twitch response as you palpate through that. Interestingly, I can see a little bit of that local twitch response respond up through the SCM muscle, which those pec fibers do link with the SCM. But I just feel a taut band there. If I were to follow that, that's going to take me into that sternal portion of the muscle, and that'll help me find and differentiate where there's tautness in the muscle. For men, you have a little bit more territory you can palpate. For women, this sternal edge is a really useful area because you can palpate and feel without having to go to breast tissue. The other area where you can palpate and where it's probably easiest to needle is at the axilla. So I have access to the bulk of the muscle through here. This is where knowing those fiber orientations can be very helpful. So I can come and feel for tautness within the muscle. Pretty noticeable band in these costal fibers. And this is the easiest way to needle it. You want to be very cautious. I wouldn't do this needle technique with breast implants because you could puncture the breast implant, but barring that, it's not a problem. So I can grasp the muscle this way, feel the tension within the muscle, hold, put the guide tube between my fingers. I'm going to angle towards my thumb. I can feel the edge of the taut band. And maybe looking for trigger points, you might even get a local twitch response with the palpation. And I can hold and then advance the needle towards my thumb. I need to be really comfortable with the idea of needling towards my thumb, feeling that needle advance towards my thumb. I can bring it out, but it's very safe. A little bit of simulation there. And I can do some general lifting and thrusting, different needle angles to elicit a response to the pec major. All right, so I have a minute-long myofascial release. This was a longer technique, but this was a YouTube short. This is on the Sports Medicine Acupuncture YouTube channel, so you can reference it there. Again, it'll be in the recording. This will be the last thing we have for today, and you can see a follow-up technique to the needling. Myofascial release for the pectoralis major will take place with either the patient having their arm down by the side, especially useful for the clavicular head attachments, or having the arm up above the head in external rotation, much better for the sternal and the costal fibers. And what you're going to have the patient do is start to turn their torso, start turning towards your same side. So you want to have the fibers shorten so that you can get in and get a good investment, get a good grab of the tissue, and relax there. And then have them turn away from the shoulder. So they're keeping the shoulder on the table and trying to a little slower, turning the torso away. And they're having to learn how to relax that pectoralis major while you're spreading through it. All right, very nice. So feel free to check these videos out. Like I said, the references along with this recording will be on the on my channel. It'll be in multiple places, but it'll be on my YouTube channel. The QR code is there, but also the webpage along with Sports Medicine Acupuncture had that myofascial release technique. So I think I can take off the slides. And just to give a quick idea with that myofascial technique, in that exercise we were doing, we were moving the shoulder away from the rib cage to get more space. And by that, the front of the rib cage, I should say. So that ability for pec major to move, kind of like I'm throwing a ball, I have to be able to expand and move that shoulder away. The myofascial technique, we did it slightly different, as we compressed and moved the sternum closer to the humerus, and had the patient relax the shoulder on the table while they moved the sternum away from the arm. So same thing, but just different reference point is they were kind of learning how to relax the pec major so that they could turn the sternum away from the arm. And in the exercise, they were moving the arm away from the sternum. So same idea, just a different focus. Both of those are going to require the pec major to lengthen. Both of those are going to open the heart a little bit, or at least the heart channel, heart sinew channel. So great exercise. If you have any questions, feel free to comment on the webinar. I'll be checking those, and maybe it's something you can add to your routine, definitely with patients. But even yourself, I think that mobility exercise is a really fantastic exercise. So thanks again for American Acupuncture Council for having me. Dr. Martha Lucas will be here next week. So check out next week. And I will see you guys again another time.